Oh, they just, oh, I'm sorry. Yeah. I thought you meant, yeah.
Good afternoon, everyone. We'll call the committee to order. Play the roll, please. Michelle.
Senator Singer.
Here.
Senator Hopeseffel. I'm sorry. Is that here? Senator Corrado. Senator Rice is not here. Senator Logano. Here. Senator Gopal is not here. Senator Cody.
Here.
Senator Madden.
Here.
And Senator Vitale.
Here.
Thank you, Michelle. Thank the members for being here today, making the time for this important issue. As you know, in the past 2 months, several facilities have experienced outbreaks of infectious disease in the pediatric population, some of which have tragically resulted in deaths. I know all our hearts go out to the families and loved ones affected by the unfortunate events at Wanacue for Nursing and Rehabilitation and University Hospital. We mourn them and empathize with their sadness and their anger. The purpose of today's hearing is to understand what happened and identify ways to prevent and continue future facility-based outbreaks, to contain future facility-based outbreaks. Specifically, we are here on a fact-finding mission. We want to understand the timeline and the sequence of events that occurred at each of the facilities, what protocols were employed, and the state's response to date. We want to identify any shortcomings or failures that may have occurred that led to adverse outcomes, and in some cases, any best practices that were followed that may have led to more positive outcomes. And finally, we want to offer our assistance as legislators and policymakers to identify those changes that we may advance or levers we may offer to ensure outcomes in the future. As I understand it, the events that occurred at Wanacue Center for Nursing and Rehabilitation, University Hospital, and Voorhees Pediatric Facility are unrelated and very different forms of the type and strain of infectious disease, the severity of the disease, and the unfortunate outcomes. The adenovirus strain at Voorhees Pediatric Facility is not the same strain as that was identified at Wanacue and is associated with a milder illness. And University Hospital experienced a different bacterial infection altogether. Nevertheless, I'm sure there are lessons to be learned from each of the facility's responses, as well as the state's response, that can inform and improve future best practices for our citizens and those patients in those facilities. The committee did invite, and the chair did invite, representatives from all 3 facilities to appear today to testify, and all 3 declined to come in person to testify. That troubles the committee. It certainly troubles me as the chairman. We did receive early on a text message and a letter or 2 today sort of outlining their basic procedures and policies at their facility and expressing their sadness and grief and the outcomes of their facilities, but that doesn't change the fact that they should have been here today. Legal advice aside, this is too important for the patients and the citizens of this state and for the families who suffered so tragically over the past several weeks. And before I invite our first guest to come to the witness table, I'd asked Senator Cody wanted to make a brief remark.
Yes.
Senator Singer.
Upsetting, Senator, that company refused, in my opinion, to come here today. And if they refuse again, I think we should seek subpoena power from the full Senate and drag their butts in here and let them explain to the public what happened. The other thing, in reading all the briefings we were sent, what I've read and everything else, I think one could adequately raise the issue, did this happen because the company put profits over patients? And I think that's a legitimate issue. Thank you, sir.
Thank you, Governor. Senator Singer.
Thank you, Mr. Chairman. I know that the Commissioner of Health will be testifying first, and I just wanted to, though it's a little bit different issue, but I wanted publicly to thank him and his staff for all their cooperation and help in the outbreak of the measles. In Lakewood, we had over 2,000 people be inoculated. We couldn't get the vaccine. His staff stepped to the plate and helped us with that and allowed us to vaccinate over 2,000 people within a short period of time. And is working with us on this serious issue, and we thank him and his staff for doing so. And I speak from both the senator from the district and also as a member of the County Board of Health. Thank you.
Thank you, Senator Singer. I'm going to call as our first witness, and so we invited the commissioner to come here today, of course, and he wouldn't. He insisted on coming today, and and we've been working very closely together over the past several weeks. He has been as informative as he can be, and keeping us, members of this committee, and the chairman informed on a regular basis, not just of the outcomes, but of the investigation and the steps that he's taking and his department is taking in trying to address this, not just what happened, but how they're making sure the facilities are operating in the best practices in the safest manner today and in the future. I'd like to introduce and come to the table Commissioner Sharif El Nahal from the Department of Health and Senior Services. No more senior services. I forgot all about we cut that away. Thanks. Lucky you.
Thank you and good afternoon, Chairman Vitale, Vice Chair Madden, and members of the Senate Health, Human Services, and Senior Citizens Committee. As Health Commissioner, as a physician, and as a father of 2 young children, I extend my deepest sympathies to the families of the 11 extremely vulnerable children who have passed away, as well as those who have become ill because of the adenovirus outbreak in the Wanacue Center for Nursing and Rehabilitation. This has been a wrenching time for family members, caregivers, and staff who have known many of these children for years. This was their home. What has transpired at Wanacue is nothing short of tragic. I appreciate the opportunity to outline the department's actions to contain the spread of the virus at Wanacue while managing several other outbreaks in recent weeks. And although the department has had to continue its work in other crises simultaneously, including infections at University Hospital, a measles outbreak that continues to spread, as Senator Singer mentioned, and hundreds of other outbreaks that the department has managed over the past year alone, nothing has rattled my team and myself more than our painstaking efforts at the Wanacue Center. It is now still early in this year's respiratory virus season. To give you an idea of how frequently these outbreaks occur, in the last 2 respiratory virus seasons, the department has managed 350 respiratory virus outbreaks in long-term care facilities, schools, daycare centers, and college dormitories. This outbreak has been extremely challenging to manage for several reasons. Adenoviruses normally cause mild illness, particularly in young children with healthy immune systems. But the type of adenovirus that has caused this outbreak, number 7, is found in communal living settings, historically characterized in military barracks, and can cause severe illness and death even in healthy people. Unfortunately, this virus has impacted the respiratory unit caring for one of the most fragile populations of children in the state. These children are ventilator dependent and have weakened immune systems, making them especially susceptible to severe illness. As I mentioned, the Wanacue Center was home for these children. And while visitors are discouraged from visiting while they're ill, it is impossible to prevent visitors from seeing their loved ones, visitors who may inadvertently introduce illness from the community. We will likely never know how it was introduced into the nursing home. Several tools available to us in other outbreaks, vaccine and medicinal cures as example, were not available to us. Another important tool, separating ill from asymptomatic patients, or a process called cohorting, was not possible to do completely at the outset due to space constraints. The same evening that we were notified of the outbreak, we directed the facility to separate the children to the extent that they could. But it was not until November, and only because of a continuously decreasing census, that the facility had sufficient space to complete the process. For the Wanacue outbreak, I thought it would be helpful to review a timeline of events, and we have passed out a chart called an epi-curve to help you follow along. After hours on October 9th, the Department's Communicable Disease Service, or CDS, was notified of a cluster of respiratory illnesses. At the time, the facility indicated that 20 pediatric patients were ill, there had been 2 deaths, and there was 1 confirmed adenovirus case. That met the technical definition of an outbreak, at least 1 positive lab test, along with other patients with similar symptoms. That evening, CDS issued directives to the facility on respiratory outbreaks and infection control protocols, including cohorting to the extent that they could, dedicating staff to care for only sick children or asymptomatic children where possible, environmental cleaning recommendations, clear hand washing protocols, the proper use of protective equipment when entering rooms. The following morning, CDS assembled an outbreak team with a full response plan. Within a business day, CDS also contacted subject matter experts at the Federal Centers for Disease Control and Prevention, including experts in adenovirus and other respiratory viruses. This close collaboration has continued throughout this outbreak with many follow-ups, and CDC continues to be an important partner in this ongoing investigation. Facility layout and floor plans were also requested to ultimately optimize a cohorting plan. When it was determined that full cohorting would not be immediately possible, the facility was asked to hold on any new admissions until the outbreak was over. The facility was also advised to notify families and visitors of this outbreak, and the local health department in Wanacue has also been collaborating with the state on the response. In order to assess the efficacy of all these initial efforts, at least one full incubation period must pass. An incubation period is the time between becoming exposed and showing symptoms. Because limiting further spread was the goal, any infection control measures implemented on October 9th would only signal reductions in new cases later in the month, as new cases are detected only when patients begin to show symptoms. Department staff became concerned that the facility was not able to implement the directed control measures at that time. I was then notified of the outbreak on Friday, October 19th, and I immediately directed an inspection team from our Division of Healthcare Survey and Field Operations to conduct an unannounced survey at the facility. 2 registered nurses, part of our long-term care facility inspection team, conducted the inspection that weekend on Sunday, October 21st. On October 23rd, after a preliminary inspection findings were in, the department announced the outbreak to the public given its severity, which then included 18 confirmed pediatric adenovirus cases, including 6 deaths. CDS also conducted an in-person site visit at Wanacue on the 23rd as well. Their role is distinct from the survey inspection team. It is consultative rather than enforcement-based. The following day, Governor Murphy joined me for a press conference at the center, and that day I also ordered a CDS staff member to remain on site at the facility for the duration of the outbreak. The role of that staffer was to provide faster updates on cases and to be a resource for infection control efforts. That day, I also chose to make the preliminary results of the inspection public to be transparent about the department's actions that would follow. On October 29th, I ordered a special team of infection control experts and epidemiologists to deploy to all 4 pediatric long-term care units in the state that care for vulnerable children, as well as University Hospital. These special infection control assessments and response teams, or ICAR teams, normally assess infection control issues at the request of facilities to help prevent outbreaks before they occur. Wanacue was their first stop on November 1st. A survey team returned to Wanacue between October 30th and November 14th in response to multiple complaints that followed, finding serious infection control deficiencies at that time. And as a result, on November 14th, the department announced enforcement actions, curtailing formally all new admissions, including to other units, until the facility hired infection control experts. The curtailment of admissions to the pediatric respiratory unit was ordered to remain in effect until Wanacue demonstrated that it was able to fully cohort the patients. That means physically separating into different wings of the facility adenovirus positive patients, patients with milder symptoms who haven't yet been tested, and patients that had not developed symptoms. When I learned that space became available to completely separate patients, I didn't wait. I called the Medical Reserve Corps to send in staff to the facility that afternoon. Moving these patients is complex and requires specialized staff to sterilize rooms, move complex equipment, and handle fragile patients. The facility then mustered its own resources to complete the cohorting a day and a half later, on Saturday, November 17th, obviating the need for the Reserve Corps. And there were other concerns about the Reserve Corps that my team raised. Cohorting was confirmed by my staff in person, and a surveyor returned to the facility again for inspection on November 19th. This extensive list of actions taken and public announcements made during the outbreak exceeded protocol and standard operating procedure given the extraordinary circumstances. Measures that went beyond protocol included deployment of the ICAR team, calling up the Medical Reserve Corps, having an on-site CDS staff member, and even planning for a mobile emergency room unit normally deployed for medical disasters to achieve cohorting earlier. And this was ultimately not done on the advice of CDC, who advised that it could actually confer an increased risk to these fragile patients, but just illustrating the amount and the extent of options that we considered. Since cohorting was completed on November 17th, there has not been a single additional patient that has contracted adenovirus at Wanacue. I would be remiss not to mention an ongoing investigation in the neonatal intensive care unit of University Hospital in Newark, where 4 infants were confirmed with Acinetobacter baumannii, a bacterial infection. On October 25th, the department ordered a directed plan of correction that required University Hospital to hire a full-time certified infection control practitioner to guide efforts, and major infection control deficiencies were found. The department learned a week ago that 2 of the premature infants died over the Thanksgiving weekend. Although due to underlying medical conditions related to their prematurity, the bacterial infection may not be the cause of death. No new NICU infections have been confirmed since October, when the department ordered an external prevention expert to guide efforts in the NICU at University. We had previously announced that another one of those infants passed away at the end of September. Last Monday, when we learned of these deaths, a department survey was sent to University Hospital to investigate the hospital's internal notification policies, governance, and other factors that relate to the reporting of cases, deaths of cases, I should say, during an ongoing outbreak. That investigation is ongoing. On to policy solutions and system fixes. There is much that we can learn from this tragedy to minimize the chances of it ever happening again. We can and must work together to improve the system. First, internally at the department. Because of what has transpired, I've done a thorough assessment of our own response. Department staff's public health management, which focused relentlessly on controlling the spread of infection, was implemented meticulously, per protocol, and in close consultation with the CDC. I will preface our internal reform efforts by saying that survey inspectors, and when they land for information gathering, do not have direct bearing on controlling the spread of infections during an outbreak. Again, that depends on all staff following all protocols for every patient, every time. An on-site presence gives us information and can be supportive, but practically cannot guarantee what is really required. However, I do believe that leadership at the highest levels in the department need to be made aware of severe facility outbreaks immediately, in case deviations from protocol are warranted. Therefore, I have directed through new internal policy that both CDS and survey leadership immediately notify me and the Principal Deputy Commissioner of any outbreaks where pediatric deaths have occurred, among other criteria for severe outbreaks. I'm also now personally in the notification system for all new outbreaks reported. There are literally several per day on average, so a separate notification process from my team for severe outbreaks is prudent. Outbreaks like these also raise important policy questions. On the topic of preparedness, facilities must be prepared for how to respond to outbreaks because we know that they occur even in the best facilities with no infection control issues. Outbreaks are not always preventable, but when they do occur, facility management must support staff in instituting all proper infection control protocols immediately. Policies that better support the department with more resources to train facilities, require infection control professionals to be available, and require infectious disease physician consultation when needed could lead to better preparedness in providers across the state. This outbreak also highlights the importance of being able to cohort patients effectively in facilities that take care of ventilator-dependent or medically fragile patients, and the prudence of having clear plans for how to do so when outbreaks occur. On enforcement, this event has raised important questions about whether state-level standards for inspection should be unique to long-term care facilities that serve medically fragile patients to give the department more latitude to enforce action in these facilities if warranted. This would require more resource support for survey staff, which the department has been very focused on hiring. I want to thank the members of the legislature for their partnership on improving the healthcare system, especially the system that cares for such vulnerable patients. And I look forward to working with you to advance measures that protect these residents and protect public health moving forward. Thank you.
Thank you, Commissioner. I think the members will have some questions for you, but let me just begin by saying thank you for being so transparent and so informative. One of the questions I think we will all have is, and you did provide to us the timeline from, at least for now, my question will be focused on Wanacue Center. When the first patient became symptomatic on September 26th, how many patients became symptomatic after that date and before they were tested? Do you know the answer to that?
What I know, Senator, is that when we were notified, there were 20 symptomatic patients. And that day, there was a positive lab test that came back for adenovirus. So that met the technical definition of an outbreak, which is required to be reported to the department.
Is there a number on terms of the outbreak, 1, 2, 20? Is there, before we define it as an outbreak, is there a number?
It has to be at least 2 patients with 1 positive lab test. There is another definition, which is that if you see a certain number of symptomatic cases above baseline, that's also a definition for an outbreak that can be used.
So 20 patients became symptomatic, and they all shared the same symptoms generally?
They shared a similar profile of respiratory symptoms. I don't think exactly the same.
Upper respiratory distress and some other things? Okay. And so we get to number 20, and that's when they tested? Did any patient die in between that number, between 1 and 20? Did any patient pass away?
When we were notified, there had been 2 deaths.
And this is after the 20th infection? I'm sorry, the 20th observance?
Yeah, so what coincided when we were notified was 20 total symptomatic cases,
Right.
of which 2 had passed away.
But you were notified because there was a death, is that right? Not because of was it both, or is it one or the other?
We were notified because there was an outbreak. So the notification requirements for public health issues, there are certain diseases where you have to notify of every single case. West Nile virus is one of them. We hear about every case. For adenovirus, which is quite common in the community, we only hear about occurrences in facilities when there is an outbreak, and I gave you the 2 definitions for an outbreak.
Right. So it seemed to me that, and that, I think on the surface it sounds reasonable, but when we're dealing with a population like this who are so medically fragile, where one thing could have an adverse outcome, it would seem to me, at least as a layperson, that after the 5th observance of a medically fragile child, or 2 or 3 or 4, exhibiting some of the some of the same symptoms, then we get to 15, then we get to 20. It would seem to me that if I were running that facility, I might say, I think we should test, because there are that many medically fragile children experiencing much of the same symptoms, and we need to find out what this is. And they test, then it's adeno, and then they act, right? But they wait until there are that many, and maybe that's the typical protocol for adeno because it's so common. But among children in this kind of condition, it would seem to me that any virus, any illness, any symptom, particularly if it happens to more than one, and it may not be severe, but it's happening across, a variety of children, that ought to trigger some action on the part of the facility in terms of, and then of notifying your department. And I know that you and I talked about early notification, and just as it relates to this type of population or some other outbreaks that are similar. So Wanacue waited until there were over almost 2 dozen before they notified the department? It was 20?
Yes.
Okay. Thank you. And I know that and after we talk about Wanacue a little bit with the members, we talk a little bit about University Hospital and those challenges as well. And I may have more questions as well. Members, let me go. Senator Cody.
In your view, at what point do the owners have a responsibility to notify you? After 1, 2, or after 20?
Well, Governor, I'll say, firstly, that the requirements for reporting occur when there is an outbreak, when it comes to adenovirus. And so that technical definition was met on October 9th, and that's when they notify us. There is still an ongoing investigation of this outbreak. We won't have the full report until the outbreak is over. That will be over, hopefully, in mid-December if we don't see any additional cases. And I think we'll have more insight into the behavior of the facility leadership at that time.
Okay, but let's go back. Why October 9th? Was it based on number of patients?
It was based on the technical definition of an outbreak triggering. So
I thought
again,
you said before 2.
2 with 1 positive lab test.
Right, but
There were no lab tests.
there was many thereafter. More than
Yes.
just 2.
But there were no lab tests.
So they didn't notify you when it got to 3 or 4 or 5.
Because there were no lab tests. They didn't do a
Well-
lab test. Right.
Okay, they weren't doing the lab test.
They didn't, right.
And if those patients are shifted from their facility to a hospital, they lose reimbursement for the bed, correct?
Yes. I will say, Governor, that there isn't an immediate recognition necessarily after the first case, or maybe even a few.
I understand that, could be.
Right. That does depend on their baseline, and these children at
It all
baseline
depends
do
what
have.
what baseline they're caring about.
Right. Exactly.
Can we somehow change that so that something like this couldn't happen again in terms of when they have to report?
Yeah, so Governor Cody, I think there is room here for exploring policy considerations when it comes to infectious disease consultation. We have, as part of our enforcement action, required WANAQ to hire not only an infection control preventionist from externally, in addition to what they already had, but an infectious disease practice of physicians that consulted on their management and helped them with clinical decision-making on the cases. Where we have that type of support for long-term care facilities, I think, will see hopefully better outcomes and clinical decision-making that is helpful.
Right. And by the way, your inspections are unannounced, correct?
Yes.
Okay. By the way, have you looked into who, because in my readings, it was acquired in 2014 by the WANAQ Real Property LLC, which then leases it to the nursing homes operators, which is WANAQ Nursing and Rehabilitation LLC, which, by the way, is owned by Continuum Healthcare LLC. Why all the layers?
Governor, I can't speak to their management structure. We were focused on controlling the outbreak.
No, and I understand, and that's what it should be. But all these layers, it's kind of suspicious as to why that is. And is there a shifting of monies that make it easier for them and more profitable or whatever? I don't know, but it just doesn't seem right to me, sir. Capiche?
Yes, sir.
I'm not Italian, and neither are you.
Senator Singer.
Thank you again, Commissioner, on the outbreak we had, and it's still going on, unfortunately. Let me ask you a few basic questions that I think they're important to look at the overall issue. Number one is we do need more beds statewide and more diversity in the area. For example, Central New Jersey doesn't have enough of them. Is there some sense of a call coming out in the near future for vent beds for these children within the state?
Yeah, thank you for asking that, Senator. So that is something we're actively exploring. We had a certificate of need call this past January that called for 17 additional beds for these patients. And so rather than try to amend that certificate of need call to ask for more, we decided to proceed and finalize that. So there will be 17 beds that are given to the existing facilities in the state to make sure that we're expanding capacity sooner rather than later. We will have to explore the need for even more beds, especially if there are new requirements for the ability to safely cohort patients. That would require sufficient space in addition to a number of other factors to be able to do that safely, for people to have a plan, for facilities to have a plan to do that, which may require more beds and more capacity to meet the need in the state. So we'll be actively exploring that.
Just one other thing on that. My concern is the cohorting situation. If you go to facilities, and I've been in them, and I'm sure the rest of the committee has also, they don't have empty spaces. Unfortunately, you just can't build a facility and say, okay, this wing is empty. Is there any thought about requiring them or developing maybe temporary type of trailer-type facilities that would be on site and available if necessary to use? Granted, there's an expense to that, and maybe the state would have to grant something to that, but I really think that if we wait for them to say, okay, I'm going to build a wing that we're not going to use, or they're going to have empty rooms that are not going to be used, that you're going to find people not bidding on it. But can we look for alternative ways to solve the problem, to allow them to have maybe, as I said, a trailer situation or something that would allow them to have that, be able to cohort that way?
It's interesting that you had that thought, Senator, because when we were really exploring every option we possibly could on trying to help the facility cohort the patients faster, one of them was exploring a mobile emergency unit, which is typically deployed in public health disasters, to give them exactly the room that you're talking about to be able to cohort. Now, for this particular situation, we were advised by experts that that could actually confer increased risk, and so that would need to be assessed. But broadly, space is one of many important factors in being able to completely separate patients in the way that Wanacue was able to eventually accomplish. So that does have to be considered.
And just one last question, if I might, Mr. Chairman. You know, there's also a danger of moving these patients to a hospital, and the issue with the hospital, is there not, or am I mistaken by that?
Well, Senator, that is a patient-by-patient decision. So the issue of deciding when a patient needs to go to a hospital is a clinical one, made ultimately by the attending physician on record. You pretty much have to determine that the benefits of higher level hospital care outweigh the risks. And so these children are have many medical problems at baseline and shouldn't be transferred to the hospital until they get ill enough for that to be required for that reason. And so that's an important dynamic and balance that you bring up for consideration of when that clinical decision needs to be made.
Thank you, Mr. Chairman. Thank you.
On that subject, briefly, and I know Senator Lagana would like to ask some questions as well, and Senator Madden. On the topic of cost, there's been some reports that, and it's not even just, it's fact that the New York Medicaid reimbursement is greater than it is in New Jersey. There have been some allegations that of the facility in Wanacue that patients from New York are favored over patients from New Jersey, based on the reimbursement model that they employ in New York. And I don't know what the number is, but it's significantly higher than New Jersey's reimbursement rate for a Medicaid patient. And so, I mean, that's something that we're looking into, and I'm sure could that be part of your investigation? Let me just preface this by saying that some of these children are have families, immediate families, and some potentially have guardians, and some are wards of the state, and I'm not so sure at the end of the day where the wards of the state will fall in terms of law enforcement and their representation in this whole process. Because that's a question we have to have answered, not by you certainly, but by maybe the Attorney General. But do you know what the percentage of New York patients are versus New Jersey patients, meaning Medicaid residency, whether it's New York or New Jersey? Do you know the difference or the answer?
For Wanacue specifically?
For Wanacue specifically, yeah.
So I will submit through you the exact breakdown. It's roughly 2/3 New York, 1/3 New Jersey.
Okay. And so it's been suggested that that's a business model for Wanacue. Now, they are located in the furthermost part of the state. They're up North Jersey. But when 2/3 are from New York and 1/3 from New Jersey, and we have patients here in New Jersey who can't find a bed and parents who can't find a bed, that's significant. I have other questions, but I'll defer to Senator Madden.
Thank you, Chairman. Hi, Commissioner.
Senator.
So when you're talking about the Center for Nursing and Rehabilitation and their preparedness was your term, preparedness plan. It's my understanding this facility also has what would be called a disaster or emergency preparedness plan on record. That is all part of the steps that are taken through the county and the state also at the same time if a disaster had hit. Do you know the status of their plan? Did their plan pass inspections from the Department of Health Can you talk about that particular piece for a few minutes, if you're aware of? Do they have a competent plan for what's expected of them through the Department of Health? And what was the status of it?
Yes, Senator. So as part of the things that we inspect, they have code requirements, particularly for fire safety and the need to evacuate and a number of other disasters like that could happen. When we do full surveys, part of it is assessing whether they have adequate code requirements in those situations. Outbreaks like this, as bad as they are, from a clinical standpoint, given the outcomes we've seen, don't relate as much to those code requirements. That's really more in the event of, again, a need to evacuate in an emergency situation.
Well, let's just stay with the code for a minute, because this is where to me, this is fairly practical in terms of their response to it. And I might be taking it a little bit lighter in the sense that there's an issue here. They have an emergency, and they need to separate or move patients. And in this particular case, the decision is made to either move them outside of the facility, which you would under the plan within a fire or disaster that we're referring to. So that mechanism should already be laid out for them about simply who to call, how to transport, and where to locate these people for their continuity of care. I'm hearing talk about, well, maybe we're going to get trailers in or a mobile medical sites and things. These different options were being discussed. I believe that these options probably should have been discussed anyhow, at least during the development of this emergency disaster plan along the past months and years with the facility. It's for the success of the emergency response teams, that's what happens. Continuity of care and continuity of business operations for businesses and things are all supposed to be there. So when the notification comes to your office, it's I think on the 21st of October or something, when you're notified, the inspection team goes in, the period the inspection team is there, an individual passes away, and it's between the time you're notified and the cohorting, it's almost 1 month later. The cohorting is, as I get it, is relocating patients within the facility to separate those who are ill or showing symptoms of illness, however, versus those that are whole. Conceptually, just being simplistic about it, you know, from my perspective, I know there's an emergency plan in place. The Department of Health inspects that. The county has an endorsement, and it's channeled up through the state of these facilities. Notice is coming in that we have a real problem. As Senator Vitale mentions, the 20 confirmed symptomatic patients, but 2 deaths, I believe, within that time frame. And it takes still close to a month to do the cohorting. Could you just chat or talk to us about that? Because I'm just trying to get my arms around the length of time. If there was a fire there tonight, these people would be moved tonight. So why did it take so long to figure out how to get people relocated in a safe environment? It's
a really important question, Senator. Just to clarify, on the night that we were notified and the subsequent days, we directed the facility to separate patients as much as they could. They did not have sufficient space to do the complete separation as you described, where each wing has 3 types of patients, one with lab-confirmed adenovirus, one section with symptomatic cases that have not yet been tested, and there are clinical reasons why you wouldn't necessarily test someone with just a fever, for example. And then the third cohort is people who have never had symptoms. All separate wings, all dedicated staff. They could not do that up front because they did not have the space to be able to move the patients. And you can do so incrementally, and we did direct them to do so incrementally over time. They couldn't completely do it until November, and when I found out that they could, I accelerated the process as much as possible and directed the facility to do so with an enforcement action. I do think you bring up a really important opportunity for cohorting plans to be available in the event of severe outbreaks like this. And we can have, I think, a great policy discussion on the best way to do that, but in particular for facilities that take care of medically fragile patients, ventilator-dependent patients. We know the impact that these types of respiratory outbreaks can have. We've seen just a tragic number, 11 deaths in these residents. So thinking about requirements for having a clear cohorting plan in the event of these outbreaks, I think is a really good policy direction.
Again, just myself, if I may, Mr. Chair, kind of surprised it's not already part of the plan. Not, considering they've been there for years, but we'll pursue that. I have one question. During your initial testimony, you had mentioned that they were called upon, the facility was called upon to hold all new admissions. Did they do that immediately, or did they continue to take people?
They did. We actually asked them to not admit. They voluntarily curtailed admissions. We put that in writing, my expectation that they would. And later on, when we took enforcement action, we did a formal curtailment of all admissions to the facility, including in the other units, until they hired an infection preventionist and infectious disease practice to manage their infection control, and did a formal curtailment as well of the respiratory unit, which means that at the end of the outbreak was previously when they could admit new patients. Now they'll have to wait for us to be able to give that okay legally for them to be able to admit new patients. But they did stop taking patients up front.
And one last, the facility itself, roughly how many beds are in it?
The respiratory unit is in the high 60s. The overall pediatric beds, I believe, and I'll get you the exact numbers through the chair, is 92. And there are a number of other units that take care of adults as well.
So you still have a fixed number of beds, but to take the 3 categories of patients and moving them to different parts of the facility, cohorting still took a little less than a month.
Yeah.
It's just, from a practical sense, it's very hard to understand why it would take that long, considering the decision for cohorting options was done so early after your notification and the department's notification, like after their site inspection.
So the need, Senator, to make sure that we didn't put a patient in the respiratory unit in a different unit, because then that unit would be exposed to the risk, was there. So we were really limited to the space in the respiratory unit because we couldn't take one of the patients and put them elsewhere.
Thank you for your clarity.
Thank you.
Thank you, Chairman.
Senator Lagana.
Thank you, Chairman, and thank you, Commissioner, for your testimony. We've heard a lot about the cohorting, and seems to be some pretty significant problems with this issue. Just on a different topic, though, after you or the department went into the facility, do you look at the staffing to make sure that that it's appropriate? Look at nurses, physicians, and this type of facility. How many doctors are on staff? How many nurses are on staff? Are there specific regulations to this facility because it does deal with delicate patients? Can you just talk about that a little bit?
Absolutely, Senator. Yes, we do have regulations on staffing requirements for patients. They're very detailed and descriptive of the acuity of patients, so their needs, and it's outlined in a lot of detail what type of staffing you need per patient depending on their clinical conditions and their needs. We inspect staffing on general surveys. The last general survey, when we look at the entire facility, everything about it, was in August of this year. In terms of compliance with current staffing regulations, there were not issues found there. And when we come in for specific complaints, we look at that specific focus area. So a lot of our inspections have been focused on infection control because that's the main problem happening there. We have received some complaints on staffing, and we've examined that, and those reports will be coming out soon when they become public.
Do you believe that these types of facilities require more staff? Do you think we need to make some changes there?
I think staffing should be appropriate to what the patient's needs are. And you have a facility where you have medically fragile patients. At baseline, they have a lot of medical problems. And so you would expect the staffing of a facility like this to be more than the average long-term care center for that reason. The staffing needs to match the clinical need. And so the clinical needs of these patients are significant.
So when you have this type of serious outbreak in this facility, and correct me if I'm wrong, but this type of virus, there's no vaccine, correct?
For adenovirus, there's an oral vaccine, but it's a live vaccine. So it can really only be given to people who are healthy with normal immune systems. It would be dangerous to give it to a child with a compromised immune system.
So really the only way of dealing with this would be the cohorting or quarantining of the symptomatic patients or those that test positive, correct?
Exactly, Senator. You're limited to infection control. Cohorting is part of that. You have all of the necessary things that you need to do every time you enter and leave a patient room for every single patient, for every single staff member. Appropriate hand washing, protective gear, making sure that even visitors and staff are following those protocols. All of that needs to be done as much as possible. And those are the suite of tools that we have in this situation.
When you first went into the facility and started seeing what was happening, did you see violations, those types of violations immediately?
On the October 21st survey that we did, and we've since made the report on this public, we did find hand washing deficiencies and infection control deficiencies.
Okay. Just one last thing, just so we can kind of understand how it works logistically. When something like this happens and there is finally reporting, although it seems like we need to make some changes on what's considered an outbreak and reporting requirements, how does it work logistically within the facility? Who's calling the shots? How are they the physicians or are the nurses the ones mostly dealing with the patients, and who's directing whom?
Yeah, and it's a really important question. That is a facility-specific management issue, and there should be, from an infection control standpoint, clear guidelines and policies for every facility about what to do in the event of an outbreak. Who needs to be notified, who then makes decisions on things, for example, like cohorting, making sure all of the protective equipment is available to staff. All of that needs to be written in policies at facilities. And when we inspect, part of what we do, in addition to interviewing staff and observing staff, is we look at those policies to see if they were followed.
So right now, the facility generates their own policy, which they follow. In these cases, it's not some broad policy that all facilities have to follow.
Right, and I think that is important because each facility has its own layout, its own set of staffing, take care of a particular profile of patients. So there needs to be decision-making at the facility level to deal with their unique issues. However, I do think there's certain global policy questions that we can ask as a result of this for new standards, new requirements to discuss.
Thank you very much.
Yeah.
So on that subject, Commissioner, we, as you know, in an ICU in a general hospital, there are patient-nurse ratios. And you say there aren't those same sort of hard numbers in a facility like this. Is it based on the acuity of the patient and the needs of those patients?
It's based on the acuity of the patients in all healthcare facilities.
But we have established by rule and by law what it is in the ICU, for example. Right?
Yes, in the ICU in particular, there are specific ratios.
And so in a facility like this or others who are similar to this, would it make sense to at least have that discussion about what that should look like? You know, in a daycare center, it's 1 to 4. And these are healthy children running around in circles. And in a facility like this, where they're that medically fragile, we can, obviously you said this before, but we can have a discussion about what that could look like. You know, ratios are ratios, and they can be inflexible, and they ought to be flexible based on the acuity of the patient. But these are medically fragile children, so on a scale of 1 to, there's no scale of 1 to 10 with these patients, right? It's a scale of 1 to 3 or 2, right? They are really in tough shape. So there's not a lot of wiggle room in terms of acuity for these patients, right?
Well, you know, they can be different in a lot of ways in terms of their needs. So first, for example, some patients are on a feeding tube that is directly into their stomach, or into their GI tract. Not every patient has that. A number of patients are on a ventilator through a tracheostomy. You know, so there are clinical issues that are different between patients, but also the level of care, the equipment required, their dependence on that equipment, their dependence on, you know, for example, the number of respiratory therapists that you would need in a facility like this is obviously a lot higher than average. So I think a global look at the entire clinical team and the needs that each patient has makes sense.
So I have some information that was provided by the department that sort of outlines a few seem to be violations of hand washing and infection control protocols. And on October 21st, while observing an LPN inside the room of resident number 1, Nurse 1 donned gloves, touched the resident's gastrostomy tube, repositioned the resident, and then removed her gloves without the benefit of performing hand hygiene, then touched the tube connecting the resident's tracheostomy tube and the ventilator machine. She then stepped out of the room without first performing hand hygiene and went on to another resident's room to open the window and without performing hand hygiene. Then went to her medication cart as well. In an interview with Nurse 1, she confirmed that all residents assigned to her were on a standard and droplet precautions and the importance of hand hygiene before and after residents' care and acceptable standards of infection control. So, and then it goes on to illustrate some other issues that your surveyors found when they were there. What happens to this when a nurse or other caregivers observed performing in this manner? What happens to them? I mean, they clearly had a discussion with your expert on site, with your inspector, and all the others. Is there these violations? Do we need to re-educate the? I mean, it would seem to me that if you are a caregiver, whether you're an LPN, an RN, a CNA, whatever, you have, and you're in this unit, and these children are that fragile. It would seem to me that they would have the right training, right? And so how is it that, clearly there was a breakdown here because this is how this spread, right? We know it could have been a visitor, but likely, at least from my perspective, if you look at the number of times that there's interaction with a caregiver versus a visitor, the caregiver ratio will be much higher, so there's a greater likelihood. And then the spread from patient to patient to patient. A visitor isn't visiting patient A, patient B, patient C, all the way up to patient 20. It's facility-based, in my view. And so how is it that the department, or rather the facility, isn't held sort of accountable for that? Did they understand what happened? Do they at least think this might have happened? And when I read this, these violations, I mean, what does the facility say about that? I mean, and what, I know you can restate what you're doing about that, but how is it that they, and when you leave in 2-3 weeks, God willing, and when you leave UH in 2 or 3 weeks, and the experts are gone and the training is supposed to take place, how can they be trusted to not revert back to those old practices?
Senator, you frankly bring up the biggest challenge with infection control, because it's not just about training, it is about faithful and reliable execution of all infection control protocols at all times for every patient, which is why, although it sounds simple, in terms of its execution, it isn't. And that's why we need to not only train once, but continuously reinforce that training. We need to come together as a state and figure out how we can emphasize the importance of infection control. Infection control, by the way, is a problem throughout the country in all healthcare facilities. A certain statistic that I found out recently that's important is that only about range between 40 and 90%, some assessments 40% of facilities properly do hand washing across the board. It's not that people don't think they shouldn't wash their hands and that clinicians don't find that important. It is about, again, setting up the system around them to be able to faithfully execute that. So in terms of our process, when my surveyors come in, they notice something, they cite something, they tell the facility management, they interview the employee themselves, they reinforce the importance of what they found and what can be done about it. And that's where the communicable disease service can step in, again, a more consultative service that we have from a public health standpoint, and train and reinforce the importance of this, which is why I sent the infection control assessment and response team, the ICAR teams, to every one of these facilities. But that's not the end of the journey. We continuously have to reinforce this.
By the way, when this happened after there were headlines, and everyone knew that this was an issue. I mean, when I read this, I said, had they not read the paper? Had they not seen that there were deaths in this facility and that there were dozens, over at least maybe 20 by then, children sick, and they continued this behavior? So how is it that they can be trusted not to continue this behavior? And not they, and not everyone, certainly, but a fair amount of, who knows, 2, 3, 4, 5 caregivers or more. It only takes one, right? And so I want to switch gears for a second to University Hospital and their management challenges. Did your team observe similar infection control protocol violations or challenges or problems at UH? And what did you do about that?
Absolutely, Senator. We sent both our communicable disease service and our survey and inspection team, again, different teams with different roles, although there's constant communication between them, to the neonatal ICU when we were tipped off that there was a cluster of Acinetobacter cases in the NICU. And when you hear that in a neonatal ICU, you become very concerned because, again, these are patients, these are people who have not yet developed immune systems. They're premature babies, so they're particularly susceptible to infections like this. And so the very first visit, after hearing about this, we found major deficiencies in infection control. Hand washing, the mixing of dirty and clean equipment, and a number of other issues that span staff, not just clinical staff, but environmental cleaning staff, that we noted, and we took immediate action from an enforcement standpoint to force them to hire an infection preventionist. I do want to make clear, it's easy when you read these inspection reports to think that a clinical staff that was observed, that disciplinary action should be taken, et cetera. The challenge and the discipline of quality and safety looks to the system that supports the frontline clinicians. And I think it's important to reinforce that in this discussion, that it's really the facility management and the quality management and the culture around infection control that they've instilled in the staff that needs to be examined, and what we focus on in the discipline of quality and safety.
I think you're right, and the issue of management and priorities and reinforcement of those protocols are critical. Right? I mean, in a hospital like University Hospital, which is a level 1 trauma center and a very important hospital for that part of the state, in fact, for many in that part of the state, it's one of 3 level 1 trauma centers statewide. Their existence is critical, but also the manner in which they operate is critical as well. And I don't think I think that this discussion about changing protocols, enhancing protocols, oversight is critical, and we'll have that conversation. We're talking about future legislation, future regulatory changes, and I think part of this process will allow us to contemplate some of those ideas. But in the sort of smaller scheme of things, we have a lot more control over this process than we do with, an epidemic or a pandemic, right? These are events way out of our control, that spin out of control, and before you know it, we're in the middle of an epidemic or a pandemic or something really awful. But in these facilities, and there needs to be a heightened sense of not just compliance, but awareness, which breeds compliance, of course, and leadership. And who knows whether or not it's a leadership factor at Wanacue, it's a leadership issue at university in terms of because their scores, their leapfrog scores are awful. At Wanacue, on the infection side, they're not good. And so, I mean, these are compliance issues. You are providing the enforcement part of this, and also potentially changes to the system. So I'm just encourage you to continue to do the work that you're doing in terms of trying to give us more tools for the toolkit, and yourselves the same as well. Just one last question about Wanacue for now. And when were the parents notified about the outbreak? I mean, some of the children became symptomatic, and after they became symptomatic, how long was it before either parents or guardians or others were made aware? Because I've heard some say that it was a matter of weeks, or days or weeks.
Yeah, so the answer to that question, Senator, is a little bit complex. They, with our guidance initially, did put up signs throughout the respiratory unit informing all visitors and staff that there was an ongoing outbreak. We advised them to inform the families. I believe the letter to families went out later in October. I don't have the exact date here, but we can submit that exact date to you. That is a responsibility of the facility. We do not, as the department, have information about the families to notify them, but we did give guidance to do so.
Any questions from Senator Cody? I'm sorry, Senator Rice.
Yeah, I just want to, you talk about UH, and I just want to be clear that UH has its share of problems. They're probably the worst I've seen. And I think the commission is looking at that and others as well, but I just want to give you some history going back 30 plus years. I've been here working with UH, and a lot of UH problems, of course, of the legislature and the government, the politics of it, where we continue to try to demise that institution, but you can't figure out how to do it because it's Trauma One Center, and that's why we used to fight the mergers and things. And then when we did the merger, everybody made sure the way we did the funding, that a lot of the funds that should be going to the institution is not there. So we kind of put ourselves in this bind, and a lot of times we do it here at the state because it's Newark. No different, we close United and all the other institutions up in that area there. And so yes, the leadership there is poor as far as I'm concerned. We went through a few presidents. It's probably the worst I've seen in terms of communication and things going. But you talk about UH, you need to talk about funding too, and that's one conversation that this legislative body don't want to have. Number one, because of political friends and healthcare facilities in your other areas. And I say that publicly because I've been part of those fights, and I've called some of those people out. And so hopefully you don't see this as a way of demising the institution, but you see the way of making it more healthier and going back on the commitments of funding and getting the kind of staffing that's necessary. So I just want to say that for the record.
Well, thank you, Senator. I appreciate that. And you're right. University Hospital is a very important facility, and I can speak for the members of this committee. No one's wants to see its demise as well. In fact, the governor recently appointed a monitor for University Hospital to work in concert with, as best that she can, the leadership of that facility to make certain changes and to provide the level of oversight that's necessary. Hopefully, while it is that changes in leadership take place and we make University Hospital a better place for everyone.
Yep.
Governor Cody?
Yeah, just, Commissioner, when the patients are removed from the hospital, they lose the income from the bed, correct?
Yes, the bed hold is required by our department. In other words, there needs to be at least a 10-day period where the facility holds that bed for the resident. This is their home, and so...
Senator Vitale and myself did that years ago.
Yeah.
But once that finishes, what happens?
There is no longer a requirement after 10 days, and when they're transferred to the hospital, they do not receive payment.
And how much do they lose per day per bed?
It's different for each facility. In the case of Wanacue, it's I think 512, but I want to make sure I have an accurate number on that.
Okay, so when you add up all those patients, that's a significant amount of money.
Yeah.
No comment?
Well, Medicaid policy is not our particular department.
No, I understand. I know that very well.
But that is the situation.
Thank you. Any more comments? Senator Corrado? Thank you.
Thank you, Chairman. Commissioner, just briefly, maybe going forward, one of the things we can look at is putting in a policy where we notify the families sooner. There's got to be a better way to do it than by letter. In this day and age, it's certainly a phone call, email, and a better way than just putting up a sign in the facility. So maybe that is something we can address as well.
I think is an important policy consideration, Senator.
Thank you.
Honestly, I'm sorry, Commissioner, there was a question. I know that one of the families who are here today are either thinking about or planning to bring their child home to care for him at home. And he's older, I think he's in his teens, which presents different challenges for a parent. What would you say to, I mean, what do you think it would take? I mean, of course, there's the round-the-clock care that I would want as a parent, at least for a longer prescribed period of time, because they're, again, depending on the acuity of the patient, if they're on a vent, or they, whatever that happens to be. And I don't probably blame that parent for wanting to take their child out of that facility because of what happened to them. And they got sick and could have died. So your observance of the patients who were there, how are they different? I know that certainly with ages they're different. If they're very young and UH, they're preemies. At Wanacue, they're up to late teens, maybe mid-teens, and younger. So what do they, in terms of their illness or their condition, what does that look like?
So a lot of these patients, Senator, require ventilation. So they have a tracheostomy that's basically a hole in the neck where a ventilator connects directly instead of having to go through the mouth. Right. That is for patients that need ventilator support. They can't breathe safely on their own. A lot of these patients, as I mentioned, have feeding tubes. A lot of these patients have seizure disorders that require not just oral anti-seizure medications, but in the event of an emergency, a severe seizure IV medications. So I think ultimately many of these patients would need facility care based on their conditions, although it depends on the patient, depends on the residents. So some of them you may be able to set up home care that's safe, but we wouldn't be able to say that for all of them necessarily.
Thank you. I know what your schedule is like for the rest of the day, but if you're stick around for a few more minutes, we'd appreciate it.
No problem.
Thank you, Commissioner.
Thank you, Senator.
Thank you.
Thank you, sir.
After our next panel, I'm going to invite some of the families to come up with their representative. But first, I wanted to ask Senator Cardinale, Assemblywoman Schapese, and Assemblyman Auth, if they are here, to please come up to the table. As I said, you represent the district where Wanacue is located, the rehab center, and as I said during the Commissioner's testimony, we'll work together on potential legislative fixes or potential policy fixes that we all deem to be appropriate, and thank you for your interest in that.
Thank
Senator.
you very much, Chairman Vitale and all the members of the committee. The acoustics in this room are terrible. Sitting in the audience for the first time, having sat at that table for many committee meetings, I really feel for the audience, trying to hear what has been said, and especially in an important meeting like this, we should perhaps, I guess it is being recorded and it will be available to people. But I want to thank you for holding this hearing today and for giving us an opportunity to discuss this very important issue, which will allow us to develop a plan that this kind of tragedy does not continue to occur. And I want to thank very much the Commissioner for all of his efforts during this very trying time and for the transparency that he showed in allowing us to all be kept fully informed, and for the efforts that he made. And when you consider the time between infection and symptoms, the department was under real strain because it's a 14-day time. So by the time they got in, there were a lot of cases that would continue to develop no matter what other procedures he instituted. But this is a very heartbreaking problem for parents who have children in facilities, not just for the parents who lost their children, but for all the others who have children that are in state overseen facilities who have to worry that maybe this could happen to their kids as well. And these parents should not have to fear that their children will become the victims of a similar outbreak. The state of New Jersey and all privately operated facilities needs to be held to a higher standard. We need to hold ourselves to a higher standard. One of our most sacred responsibilities as public servants is to protect our children, and particularly the vulnerable children who are in these sorts of facilities. I believe that the members of this committee will all agree that serious actions are necessary to guarantee that no more families suffer the excruciating pain of losing a child or the fear that that may occur. The children who died as a result of the outbreak at Wanacue were already at high risk of infection. They needed more care and more oversight, not less. My prayers are with all of those who are grieving, but they deserve much more than our thoughts and prayers. Far too many parents are still struggling to try to figure out what went wrong. It's my hope that during today's hearing, we will begin to provide answers for those families and ultimately enact tangible solutions that guarantee not a single life is lost again. That may be a high goal, but it is a high goal that I think we should strive for. Part of the reason the outbreak of a dangerous strain of adenovirus was so deadly was because the children who were affected were already so medically fragile, and proper protocols were not observed. We have learned that another part of the problem was the facility's inability to quickly separate those who were showing symptoms of infection from those who were not. We must ensure that going forward, every pediatric facility has a plan and the ability to cohort patients to prevent dangerous viral outbreaks from spreading. Now, we've heard a lot about what cohorting is, so perhaps my explaining it again is redundant, but I think it should be explained again. Because I have introduced legislation that would require pediatric hospitals in New Jersey to develop a plan to cohort patients who exhibit signs of potentially contagious infections. Cohorting is more than just separating in space. It is separating the people who will treat them. It is separating the materials that are going to be used, the equipment that is going to be used, so that we don't have opportunities for cross-contamination. Cohorted patients need to be treated by dedicated staffers, dedicated to that group of patients, so that both the patients and the people who are treating them are protected. Every parent of every patient deserves to know that their children will be safe when entrusted to a pediatric hospital, and that we're going to force those facilities to develop plans that provide that assurance. Without this kind of legislation, many medically fragile children in the care of the state will continue to be at risk. Respectfully, I request that this committee review that bill as soon as possible. It's one of the best ways to stop another outbreak from getting out of hand. It's disappointing that caregivers, many of whom our highly trained and licensed certified professionals were so lax at infection control. Even when they knew they were under observation, they continued, many of them, to be lax. There has to be some accountability for that on the part of the individuals as well as the group. It is a very great concern to us that parents were not promptly notified when their children became ill. It's troubling that once these children became ill, they were not promptly hospitalized. Were monetary conflicts at issue? Many have speculated that there was a monetary motive for not hospitalizing the children. We must have better regulatory oversight over these practices. I want to close by thanking you for hearing my testimony today, for taking this matter seriously. This is the least we can do to deliver some sort of justice to those who continue to grieve in the wake of Wanecu's outbreak. And I am very grateful for the efforts of this committee. Thank you.
Senator, Assemblywoman.
Thank you, Chairman Vitale and members of the committee. I'm Assemblywoman Holly Schapese, and I, along with Senator Cardinale and Assemblyman Auth, represent Wanecu as part of our district. And we're here today, one, to thank you for holding this incredibly important hearing. It's probably one of the biggest health crises to ever impact our district and potentially even the state in modern times. As we sit here today, 11 children have died, 35 more have been infected. And I think we all, and hearing some of your questions as well, we all continue to struggle with trying to understand how and why this happened and what we can do as legislators, if anything at all, to try to prevent future things like this occurring. My hope is that out of this, we've heard, as the senator said, some troubling, rumors and facts and patterns that have emerged. And we hope that we can work together with you, as well as the commissioner, as we've been doing, to ensure that we put forth legislation that can help prevent tragedies of this magnitude, that we can ensure that parents and families are properly communicated with if their children fall ill, that they can make informed decisions about their loved one's care if they are critically ill, that we investigate whether or not the facility was properly engaged in cleanliness, sanitary conditions, and whether or not the allegations that potentially these patients were kept in their beds, these children, were kept by a facility longer than they should have been rather than going to a hospital due to potentially financial gain and Medicaid funds flowing, that if that is in fact accurate, that we do everything within our power to try to make things right. As a mother of 2 children, one of which was actually in a pediatric wing of a hospital over the past week having major surgery herself, I got to understand kind of firsthand as a parent the concerns that you have in watching your child. And with the knowledge that we have of the various outbreaks that have been going on in pediatric facilities around the state, I know I, as a parent, did everything in my power with my daughter's doctor to get her out of there as quickly as possible because of the fear of infection that we have. These children, these parents, don't have that ability. These children are in facilities for life. They're not going home to get better. They are amongst the most fragile in our entire state. And as a result, we have an affirmative obligation to do everything that we can to make sure that something like this doesn't happen again. My office has spoken with several families of who have children at this facility, who have loved ones at this facility, and they shared with us that there was no communication whatsoever. That in some instances, parents were finding out that their child was going to die hours before the child died, and several weeks after the facility was aware of these children being ill. So, you know, as a baseline, and it's been discussed today, Senator Corrado mentioned it, Senator Cardinale, you know, the fact that we even have to legislate communicating with families and loved ones seems a little bit surreal, but I think that's a first step that we must take to ensure that those lines of communication are open, to give those families an option about doing the right thing for their child's care. We also spoke, in echoing Senator Cody's comments, we need to hear directly from the facility to ensure that profits didn't come before the patients, to try to understand why these lag times existed. We heard from the commissioner, September 26th was when the first patients became ill. By the time Department of Health was notified, we have 20 patients and 2 deaths. You know, that seems to go well beyond when notifications should have taken place. We as a team have been in regular contact with the Commissioner to discuss possible legislative initiatives moving forward, and those do include Senator Cardinale, and we've sponsored in the Assembly the legislation about cohorting in future outbreaks, and ensuring that a facility has a pre-approved plan in place. You know, as I believe Senator Madden had said, you know, what would happen if the facility burnt to the ground today? They would have to move those patients. Why couldn't they have done something with these patients prior to us getting to this point? And I think that moving forward, to ensure that those plans have been reviewed by the Department of Health, have been signed off on, is a small step moving forward. We know we can't legislate away outbreaks. We know that other things are coming down. We've seen it since this happened, whether or not it's University Hospital. Today I heard that there were 22 cases of the adenovirus strain 7 reported at University of Maryland, with a death there. It's a function of society. We will have these sort of things, but we can ensure better protocols and better ways of handling this moving forward so that next time we don't have 25 deaths. So we are here to work in conjunction with you, with the Department of Health. We appreciate how seriously everybody has taken this, and for inviting us to come and speak today on behalf of our community. So we thank you.
Thank you, Assemblyman. Assemblyman Auth.
Chairman Vitale and members of the committee, thank you for taking the time to listen to us today on behalf of our constituents. It's very difficult to even fathom what the families might be going through and how they're trying to reconcile and deal with this, and we can only offer our prayers and condolences and offer any opportunity we can to fix this so it doesn't happen in the future. 6 major factors identified by the Institute of Medicine in 1992 as contributing to infectious disease emergence and reemergence were advances in technology, increase in the volume of speed of international travel and commerce, microbial adaptation and change, and the breakdown of public health capacity at the local, state, national, and global levels have intensified over time. Emerging pathogen outbreaks in the United States and abroad can occur with little forewarning, disrupting hospital operations, limiting capacity to provide services to patients, and possible compromise of the safety and healthcare personnel. While outbreak management is a major area of responsibility for healthcare epidemiologists, many do not have formal education in incident management or preparation to work within an emergency response framework. In May 2016, the Society of Healthcare Epidemiologists of America and its members submitted protocols along with Centers of Disease Control Prevention that created an outbreak response training program that includes panels of experts in the field. They developed a multifaceted educational training guidance program provided by their advisory panel and expert guidance panels and education panels. Many resources describe the specifics of how to manage patients with a variety of infectious diseases, including the infection prevention and control elements. However, knowledge and guidelines and guidance are insufficient to prepare healthcare epidemiologists for the complexities of managing a facility-level or emerging pathogen outbreak. To optimize the facility's ability to manage an infectious disease outbreak, the healthcare epidemiologists should work with emergency management committees relevant to planning committees, regional emergency preparedness committees, emergency department staff, and public health departments to assess how to adapt the emergency management plan to respond to infectious disease emergencies. The healthcare epidemiologists should be involved in the development, maintenance, and evaluation of facilities' emergency operation plan as it relates to infectious diseases and should provide input to modifications needed to address specific infection diseases. So they decided to give a set of guidelines, and I read these guidelines and listened to the testimony, and multiple guidelines were broken. The first, which I thought was most relevant, was surveillance to detect and report infectious threats. From the testimony, we had healthcare professionals who were engaging in improper protocols that were creating disease and infectious threats. We must consider possible options of having camera monitors in rooms in the hospital to detect whether or not the professionals are acting in accordance to what they've been told to do. Policies and procedures including but not limited to screening and triage patients, placement, cohorting, transporting, patient care, environmental documentation, and post-mortem care. Triage of patients, healthcare professionals, visitors, and volunteers, everybody walking through the hospital. Hospital readiness related to infection prevention, such as availability to isolation rooms, personal protective equipment, and hand hygiene and products and stations. The Senator Cardinale mentioned that our bill is talking about cohorting. It seems to be one of the most practical and efficient ways to eliminate an outbreak of infectious disease if we can get the patients that have been identified as having the disease out of the area where other patients who have not been exposed to it are residing. Patient populations that may be disproportionately impacted are children, immune-compromised patients, and pregnant women. Education for healthcare professionals, including physicians, direct care professionals, healthcare professionals, students, and volunteers. Occupational health policies and procedures, including but not limited to non-punitive sick leave and post-exposure time off. Protocols for specific pathogens. Communication protocols to include coordination and communication with local, state, federal agencies, and the patient's guardians. Informational management. Information was not streaming out of the facility as it should have been, while I will say that the Commissioner was very forthcoming with information to each of the legislators and people that were involved in this particular incidents. Laboratory issues, physical plants including but not limited to waste management, and finally, exercise drills to test and update the emergency operation plan. I believe many of these things had not been utilized during this particular outbreak, and that we must, through the Commissioner, through possible legislation, commit ourselves to reorganizing our protocols so that it's clear to facility operators, managers, that this is what's required, and if it's not done according to this protocol, that there are possible charges that could be leveled against them. Again, my thanks to the committee and to you, Chairman, for moving so quickly on this, as it is a very important issue to the folks in our district.
Thank you, Assemblyman. Are there any questions from the members? As I mentioned earlier, we have some families who are here this afternoon, and with Representative Paul DaCosta from Snyder DeSarlo et al. Tell them. Do you have more chairs? Yeah, we do. Yeah. I think we're good. There's two more people. Paul, you want to move over with just one more? Yeah. You're good. You've got all. For the record, please just to state your name and your who you represent.
Yes, thank you, Mr. Chairman. My name is Paul DaCosta. I'm an attorney with the law firm of Snyder, Sarno, Daniello, Masseri, and DaCosta, and I represent these parents that are seated here with me today. Thank you, Mr. Chairman, honorable committee members, for the opportunity to provide testimony before the committee today. I am present today to offer testimony on behalf of my clients and their unfortunate circumstances that you're all aware of. My clients are several patients and their respective parents who were victims of the adenovirus outbreak at the Wanacue Center for Nursing and Rehabilitation Center. I come before you today as an effort to give voices to their children that cannot speak for themselves. Children whose lives were dependent on receiving appropriate medical care and treatment from the Wanacue Center. I'm also here to speak for the children's parents who entrusted their beloved children to the Wanacue Center and now feel that their trust was betrayed and violated. I have the great honor and privilege of currently representing these 6 children and their families who were patients at the Wanacue Center that were all diagnosed at different times with the adenovirus. As you all know by now, all of these children were medically fragile, ventilator-dependent children. They were all, therefore, highly susceptible to communicable diseases such as the adenovirus. Furthermore, all of these children were at an increased risk of developing life-threatening medical conditions should they develop the adenovirus. Unfortunately, 2 of the 6 children I have the honor of representing did pass away as a direct result of the adenovirus. Those 2 children are Dorcas Dolson and Elizabeth Ann Polis. Dorcas was just 4 years old, and Elizabeth was only 16 years old. Dorcas's parents, Okromi Dolson and Modeline Auguste. If you could just stand, please.
My name is Madeline Auguste. That's my daughter, Dorcas Dolson.
And also with us is Elizabeth Ann Polis' mother, Christine Deli. We also have with me today Marie Beltran, mother of Brianna Rivera. We have Paula Costigan, mother of William Del Grasso. And last, we have Joel Escobar, father of Kayla Escobar. The parents that I represent do not believe that the Wanacue Center acted in the best interests of their children. They, on the contrary, think that their children's health and well-being was unnecessarily put at risk. They believe that the Wanacue Center needlessly endangered their medically fragile and precious children. As the following timeline of events will hopefully show, one of the common threads in all of my clients' situations is the fact that the Wanacue Center did not timely and appropriately communicate with them regarding the adenovirus outbreak. The only communication most of my clients received was a letter from the Wanacue Center dated October 18th, 2018, which I have supplied to the honorable members of this committee as Exhibit 1. In addition, as I've provided to you as Exhibit 1A, you will note that the letters were all sent via regular mail with a postmark date of October 19th, 2018. The letter was ultimately not delivered to these families for several days. In addition, I believe the timeline of events provides insight into the failure by the Wanacue Center to timely act to prevent and control the spread of the adenovirus. Based upon information gathered to date, and I just want to emphasize this is information gathered to date, and every day seems to provide us with new facts, evidence, and information. But provided as of today, the timeline of events begins on September 30th, 2018, when little Dorcas developed a fever. On October 2nd, 2018, Elizabeth Polis was admitted to St. Joseph's Medical Center. On October 3rd, 2018, Dorcas had a fever of 102 degrees, and her mother motorily asked that she be transferred to a hospital. Modeline's request, however, was not accepted, and she was told that the nurses were waiting for a doctor who could then possibly transfer her little daughter to the hospital. On October 4th, 2018, Dorcas' mother was informed that her daughter had blood in her trach. At that time, Modeline begged that her little daughter, Dorcas, be transferred to a hospital, but still to no avail. On October 4th, 2018, Kayla Escobar was noted to have a fever of 103 degrees along with a cough. The following day, on October 5th, 2018, Dorcas was finally transferred to St. Joseph's Medical Center. On October 8th, 2018, Dorcas unfortunately passed away just 3 weeks after her 4th birthday. As the committee has already heard from the commissioner, the Wanacue Center apparently first notified the state of New Jersey about the adenovirus outbreak on October 9th, 2018, obviously the day after Dorcas' death. From October 11th, 2018, all the way through November 4th, 2018, Brianna Rivera had several symptoms: fever, conjunctivitis, increase in her glucose baseline, diarrhea, yellow and green airway secretions, and a need for increased oxygen flow. On October 12th, 2018, Elizabeth Polis was transferred back to the Wanacue Center for palliative care, a decision that obviously was not easy for her mother, Christine. She was given the unfortunate decision of hospice care or palliative care, and she chose to send her precious child back to Wanacue Center due to the fact that many options were not available. When she does get transferred back on October 12th, 2018, Elizabeth's mother did not have any staff member from the Wanacue Center discuss or even acknowledge that her daughter had adenovirus or that any other children in the facility had adenovirus. She, as I said earlier, did receive a letter dated October 18th, 2018, but she would only receive that ultimately on October 22nd, 2018. On October 12th, 2018, William Del Grasso is noted to have a fever. On October 18th, 2018, William Del Grasso and Kayla Escobar are transferred to now Hackensack University Medical Center. Kayla Escobar had suffered with a fever and cough for approximately 2 weeks before being transferred to the Hackensack University Medical Center on October 18th. In addition, little Kayla had also suffered with vomiting episodes for approximately 4 days prior to being transferred. On October 22nd, 2008, both Christine Delig and Paula Costigan received that October 18th letter from the Wanacue Center. On October 23rd, 2008, Elizabeth Polis unfortunately passes away at the age of 16. On October 23rd, 2018, another parent who I represent, who's not here today, received that October 18th letter. At this time, I would like to please be given the opportunity to just read for the record and for the Senator's edification the October 18th letter and its contents. Dear parents, family, and/or guardian, this letter is to inform you about the recent outbreak of the adenovirus in our first floor pediatric unit. We contacted the local health department and public health nurse, the NJDOH, CDS, and the CDC. We continue to talk with these agencies daily for their guidance and recommendations. The first floor pediatric unit is under contact droplet precautions, and at this time, we are discouraging visits to the unit from non-essential persons. If you would like more information, please call Erin Norton, pediatric social worker at, and the number is given. She will answer your questions and concerns or will direct you to the appropriate medical professional. Thank you. This was signed by the administrator of the Wanacue Center. On November 4th, 2018, Brianna Rivera's parents requested she be transferred finally to a hospital. The following day is when she was finally transferred to St. Joseph's Medical Center. On November 10th, 2018, another patient with the initials of CC was transferred to Hackensack University Medical Center. After CC was diagnosed with the adenovirus, his mother was then, for the first and only time, informed that his roommate had also apparently contracted the adenovirus, although she was not told when the diagnosis was known to the Wanacue Center. All of the parents I represent entrusted their medically fragile children to the Wanacue Center with an expectation and sincere belief that their children would receive care according to accepted standards of medical and nursing care. They all relied upon the Wanacue Center and its staff to keep their children healthy and safe from such communicable diseases such as adenovirus. Unfortunately, trust these parents offered to the Wanacue Center was violated, and they and their children have suffered the consequences that my clients believe were avoidable. My clients and I thank you, Mr. Chairman, Vice Chairman Madden, and all the honorable members for conducting this hearing, which we all recognize is extremely important, and we thank you for the opportunity to be here today to testify and answer any questions that you members may have. Thank you very much.
Any questions from any of the members?
Yeah, sir.
Senator Cody.
Are you recommending to your clients where to go in terms of medical care in the future?
Thank you for the question, Governor. So that's an extremely important and timely and sensitive issue. the parents that have children that fortunately have survived are confronted with a difficult situation. The situation being that if and when they are stable enough to be discharged from the acute care facilities, which to my knowledge so far has been St. Joseph's or Hackensack Medical Center, they have no options really other than going back to Wanacue, which for obvious reasons, I believe, Governor, you can understand, they do not want to have happen. We are trying to look into the ability to have these parents potentially bring their children home. One of my clients is in the process of working with Medicaid, receiving training, but at this point it is a very precarious situation because upon the information and understanding I've obtained, the other facilities in the state of New Jersey have very long waiting periods of up to approximately 1 year. So at this point, we're faced with really a difficult scenario because it's back to Wanacue or, at this juncture, no other option.
I know I speak for the members of the committee, for all the families who are here and who are not here, our deepest sympathies, and those of us who are also parents can't imagine what this is like for you. And so we will do what we can, level best, to honor your children's memories and those who are still with us in finding solutions to this problem, and working with the Commissioner trying to get to the bottom of how this happened and why it happened and how it can be prevented in the future. It's unfortunate that it happened to you, and we will do all we will do all we can to help prevent this in the future. Thank you very much for coming out, showing your support for your loved ones, and honoring them here today. So thank you.
Thank you, Mr. Chairman.
Thank you. Association guys. Oh, this guy Paul, no, he's done it. Who's the healthcare association guy? So Dr. Gifford from the long-term care facilities, Doctor. Should bring up the Hospital Association too? Who's here from them?
Infectious disease specialist. We were going to do the Healthcare Association, the two unions,
okay.
And then the Hospital Association
Got it. Okay. Thank you for being here, and in the interest of time, also because there are several witnesses after you, if you could, not such as summarize your testimony, but you've heard everything we've heard so far, and if you could add to that your observations and your recommendations. Thank you.
Thank you, Ms. Senator, members of the committee. My name is John Dolan, and I'm the President and CEO of the Healthcare Association of New Jersey. We represent all 4 of the pediatric long-term care, special care nursing facilities in the state. We appreciate the invitation to appear before you today regarding facility-based infectious disease outbreak control and prevention. Like you, our hearts are broken for the tragic loss of life due to recent infections in our state. In my years on a Senate Health Committee and in 13, going on 14 now in long-term care, I've never seen anything like it. And it hurts. Our prayers are for the victims, their families, and all the residents and employees of the impacted healthcare facilities. The Healthcare Association of New Jersey appreciates the opportunity to provide whatever information and helpful solutions to you and the members of this committee. We appreciate your leadership, this opportunity to better understand what happened, to prevent further outbreaks, and collaborate with all stakeholders to promote the best practices and quality care in the future. Hearing from the legislators of the county where I went to high school, I cannot disagree with anything they said. And those types of ideas and those you put forth, Senator, are ones we look forward to explore today. And the more specific and tougher questions we're prepared to answer as well to the best of our ability and work with any regulatory body, government task force, or this committee to pursue legislation to improve it. As you discussed with our Vice President, John Indike, Senator, Your staff is doing all you can to provide the most relevant testimony, and in doing that, we've asked Dr. David Gifford, a medical doctor, a master's in public health, and senior vice president for quality and regulatory affairs of the American Healthcare Association, also a former commissioner or director, as they call it, of the Rhode Island Public of Health, where he dealt with an H1N1 outbreak. And I would defer our bulk of our testimony on that, and we're open to your questions on other issues that came before you prior to our testimony.
Doctor.
Chairman Vitale.
You know the word. We're going to.
Yes.
We're not summarizing, but just if we get to the highlights.
I certainly
appreciate your presence today.
Been through this as a commissioner in Rhode Island a number of times. I certainly would also like to express my condolences to the families, both of those who died and also those who are suffering through the illness there, and can appreciate both their anger, their frustration, and want to know what to do and how to prevent this. And I applaud you and the committee for figuring out how to prevent these future things from happening. Two things. First, I'd like to point out that not to get hung up on adenovirus. As you heard from the commissioner, there are a lot of other viral outbreaks that are occurring on a regular basis throughout New Jersey, including in long-term care facilities, and all of those have the same consequences in the same situation. There are a number of outbreaks across the country in long-term care facilities of other viruses that have equally as compelling, tragic stories. And so I think a mistake for New Jersey residents and citizens would be to focus only on adenovirus with this. Similarly, only on pediatric as you go forward on it. Second is to think about, and you heard a lot about it in the two previous testimonies, what you want to do is prevent the virus from coming into the facility, and then once it is in the facility, preventing it from spread, and you heard a lot about cohorting. There are a number of rules and regulations out there, and I think you heard a lot about this, that it's about consistent application and following them. I think in the written testimony I provided, go through a lot of the federal regulations that are required for infection control and what those steps are. But I wanted to focus a little bit on, and as I heard this case, gave a lot of thought of what could help New Jersey prevent this from happening again, and how to augment the current existing regulations that are there. And there are four things that we would like to offer for your consideration. First, there is currently a federal regulation to require an infection preventionist in all nursing home facilities as of November 19, and that they have specialized training in that. We would encourage you to move that date up to an earlier time frame in New Jersey, and that is of your choosing, but you need some time to implement it and get through that. We also would be willing to offer to high-risk facilities in New Jersey the online training that we've developed. And there are two other associations, one partnered with the hospitals and one with the Nursing Association that offers online training. I can't speak for them, but we'll offer that free to those facilities. We estimate there's somewhere between 40 and 50 facilities in New Jersey that have individuals that we would consider at very high risk for outbreak of viral infections that cause respiratory illness. Those are the individuals who have respiratory problems that are on chronic oxygen, tracheostomy, ventilators, people who've gotten chemotherapy, people who are on dialysis. Those are individuals who are extremely high risk of complications, and we would be willing to offer that to New Jersey as free. Three other areas, clearly to prevent the influx of these viruses. Influenza virus is by far and away the most common infection, and in this case, many people thought this was initially influenza virus, and there was a lot of testing around influenza before it proceeded to adenovirus. A lot of the influenza comes into the facility from healthcare workers and from family and visitors. We would encourage you to think about requiring healthcare workers to be vaccinated with influenza vaccine, but those who decline, which they have the right to, would then either have to wear a mask or would not be assigned to patient care during influenza outbreak in the community that the Department of Health monitors. And we'd encourage you to think about that process. A number of other states have adopted that process, and it has been effective. We also believe in, and you heard in a number of the testimonies about hand washing. You demonstrated your concern that even under observation, some individuals were not properly washing their hands through that. The readily availability of alcohol hand dispensers throughout the facility and in common areas is something you should look at, and I would encourage the State Health Department to go out and look and make sure they're placed there, because many places have them, but they're still not readily available. So even if you are aware, know how to and what to do, the readily availability of these is another problem. The third area is how do you clean and disinfect the rooms and the environment that is there. There are EPA and Center for Disease Control recommended disinfectants to be used. Not all facilities are aware of them and use them on a regular basis. But then there are certain pathogens that are very hard to actually eliminate, and that the standard disinfectants that are recommended in hospitals and everywhere else don't always work. Adenovirus happens to be one of those viruses. C. diff and a few other viruses are in that category. And when those are identified, you need to have those other supplies on hand to rapidly switch over. We would encourage you to think about working with the health department so that they go out and inspect and work with healthcare facilities in New Jersey to make sure they have the proper EPA supplies and they're using them, and that they have the extra supplies on hand to convert should those infections come out. We think those 4 recommendations would help move this along to help minimize this from happening again in the future in New Jersey. There are other things to consider as well, and I know you're thinking about those, but those we'd like to offer you as for consideration as you deal with this situation. Happy to answer any questions from you.
Joe?
Yes, Senator Singer.
Okay, thank you. I did understand that you represent all 4 of these facilities are in your association, correct?
I'm actually not sure about that.
They're members of the Healthcare Association of New Jersey, and
about is we heard in this testimony that there's a year wait in all the facilities, yet this facility is taking out-of-state patients and says they had no wait at all. How is that happening?
I will start by just giving a brief history of the pediatric. For about 30 years now, the talk began, and they went to one of the facilities, in this case, the family, and they said, we need some vents for kids. And Jersey, like no other state that I've ever seen, did a tremendous job and created 4 facilities and expanded those bed capabilities. In the case of Wanacue being in the north, when this facility changed hands about 4 to 5 years ago, I had knowledge of the beds coming over from New York. In a way, need knows no border. The other owner had a certain census dynamic. The new owner, I believe it's been dropping and not been a take care of New York. New York has increased their pediatric special care nursing, and Jersey can make its decisions and changes, as you mentioned in previous testimony, in any way, and we would be willing to work on a task force to do it. But 7 years, no incidents, better care than any state I've seen, and I've worked in 2 specifically in these areas. And I think it's an outstanding job, but it needs attention to things like bed hold, to rate, to New York census, and to other things. How did it happen? It was allowed by current law.
Thank you, Mr. Chairman.
You're not suggesting that the reason this happened is because why? Because they're, tell me again why you think this happened?
Why a New York person would be placed?
No, why, yes, why a New York person would be placed?
The need of a child to help, and maybe they live in
Do you
there, or they came
know
over
how many
from,
facilities are in New York State?
There's over 600 facilities in New York State total, but not I don't know the exact total of pediatric.
The pediatric piece. No,
I don't know.
That. Okay, thank you.
It is pretty common practice in most states that people are crossing the border, particularly Medicaid, supporting individuals when they have special needs.